Hello. Now this is my example of pre-oxygenation or denitrogenation with a mask ventilating the patient, and then from there going on to intubate the patient. So first, what we want to do is, let's say we give propofol to the patient and a little SIVO before we do the actual endotracheal intubation. We'd want to mask the patient. So you would basically have the C hold, and make sure you don't hold any of the soft tissue. You just want to hold the bone, the jaw, and your C clamp. Be careful with your thumb and your palm area not to hold or push against the eye, because that could cause bradycardia via the parasympathetic with adults, but more likely with pediatric patients. So we hold our C hold here. You want to put the patient in a sniffing position, some breaths. Now, since most of my force, most of my pressure is on the left side, you could have some air leak on the right. So what you could do, which Eileen taught us, is we have these straps over here, but I have it on the right side. So I'm going to just put one strap over here on the right. I'll just secure it. Just in case it's a short procedure, but you know, you're going to be in this position for a long time. Your arm might get tired or what have you. You want to charge, or you want to be able to have some mobility. So basically, good ventilation. So let's say we did this for a few breaths. Few tidal breaths, or a few minutes. I'm going to intubate the patient now, so here we are. Take this off. Okay, what I would take is a MAC 3. Take a MAC 3. Although I spoke to John, and on the field he says he's seen better results with a MAC 4. Because with a MAC 3 you could always go shallow, but with a MAC 4, even though you might be using a bigger sized MAC, you can always pull back to aim for that molecular. So I'll use the MAC 3. So patient in head sniffing position. You want to go on the right side of the mouth and then sweep the tongue to the left side. While we're doing this, being very careful not to touch or injure the teeth. So once we do that, we want to pull upward, make sure we're not fulcruming the patient or the teeth was injured. And you will see the left limb. Once we see that, we just pull up. Should see the vocal cords. I see the cords, so at this point we would just ask someone to maybe hand you the cord. Don't take your eye off the cords, and because you could lose it, and then basically have this in the hockey puck position with a stylet. As soon as you see the cuff underneath the vocal cord, ventilate, see if we actually are in the right spot. While we're doing this, hold the tube here. So it looks like we're in, but while we're doing this, we're listening for epigastric sound. Make sure we didn't do a esophageal intubation, and listen to our breath sounds. So it looks like I'm in the right spot. After that, and then I would put in my 10 cc's of air in the pilot lamp over here, or the pilot bulb. The recommendation is whenever, see the pilot, the air we're putting in the cuff is merely for aspiration precautions, to make sure nothing gets past the trachea. So we want to feel the pilot bulb here until you have slight pressure. Just that would be fine right there. They say 10 cc's, but I guess they did studies where 85% of MDAs and CRNAs put more pressure on the cuff. So recommendation is just so you have slight pressure. So that would be, of course we would secure it. And if the patient has a chance of biting the tube, to prevent the patient from biting the tube, we could use an oral airway here. So you just put it down, just like that, and tape it up. The final product would look like this.